Welcome to KJR SummaryCast. SummaryCast provides audio summaries of KJR articles created using an in-house AI tool with editorial or author review. For full details, please refer to the original article. Welcome back to SummaryCast.
Today, we're looking at a paper from the June 2026 issue of the Korean Journal of Radiology. It's a pictorial essay titled Modernizing Aortic Dissection Classification in the Era of Endovascular and Hybrid Repair, Implications for Radiology Reporting.
Aortic dissection classification. Most people in the field are familiar with the Stanford system. It's simple, it's binary. Type A involves the ascending aorta, type B doesn't. Why is there a need to modernize something that seems so straightforward?
Well, that's the core of it. The Stanford system and the DeBakey system before it were developed when the treatment options were essentially open surgery or medical management. They provided a clear fork in the road for that era.
And now?
Now, we have a whole suite of endovascular and hybrid techniques, TVARs, frozen elephant trunk procedures. These require much more anatomical precision for planning. The old systems just don't provide that level of granularity.
They're a blunt instrument for a delicate job.
Exactly. They also struggle with certain types of dissections, like those isolated to the aortic arch, which can fall into a gray area. So this paper reviews the traditional systems and then dives into two major modern classifications that try to address these gaps.
Okay, let's start with a quick refresher on the classics.
Sure. First was the DeBakey classification from 1965. It's based on the origin of the entry tear and the extent of the dissection. It has three types. Type 1 starts in the ascending aorta and extends down. Type 2 is confined to the ascending aorta, and Type 3 is confined to the descending aorta.
A bit more detailed than Stanford, but still fairly broad strokes.
Right. Then Stanford came along in 1970 and simplified it, which is why it became so popular. It just asks one question: is the ascending aorta involved? If yes, it's Type A, typically a surgical emergency. If no, it's Type B, often managed medically unless complications arise.
Simple, clear therapeutic implications. You can see the appeal. So what's the first modern system the paper proposes?
It's called the TEM system, introduced in 2019. TEM stands for Type, Entry, and Malperfusion.
A triplet code. How does it work?
The type part is an expansion of Stanford. It keeps Type A for dissections involving the ascending aorta and Type B for those only in the descending aorta. But it adds a new category, non-A, non-B.
And that's for those ambiguous arch dissections you mentioned.
Precisely, it carves out a space for dissections that involve the aortic arch but spare the ascending aorta. It's a small but significant group, maybe 2 to 11% of cases, that the old systems didn't classify cleanly.
Okay, so that's the T. What about E and M?
E is for the entry tear location. It's categorized as E1 in the ascending aorta, E2 in the arch, or E3 in the descending aorta, E0 if no entry is found. M is for malperfusion, noting which major vessels are compromised: coronary, supraortic, or visceral.
So it's a much more descriptive label. Instead of just type A, you get something like type A, E1, M1, telling you the dissection involves the ascending aorta, the tear is there, and a coronary artery is involved.
Exactly. It's much richer information presented in a concise format.
Okay, that makes sense. What's the second modern system?
That's the SVS/STS classification, proposed in 2020 by the Society for Vascular Surgery and the Society of Thoracic Surgeons. This one is quite different because it's built on the Ishimaru zonal anatomy.
Define that.
The Ishimaru system divides the aorta into 12 zones, numbered 0 to 11. It's essentially a map designed for planning endovascular repairs, where each zone corresponds to a potential landing site for a stent graft.
So it's a framework already used by interventionists.
You nailed it. Zone 0 is the ascending aorta and proximal arch. Zones 1 and 2 cover the rest of the arch and the great vessels. And zones 3 through 11 go down the rest of the aorta to the iliac arteries.
How does the SVS/STS system use this map?
This is the key distinction. Unlike Stanford or TEM, which classify based on the most proximal extent of the dissection, SVS/STS classifies based on the location of the primary entry tear.
Okay, an important difference. What are the rules?
It's simple. If the entry tear is in zone 0, it's a type A dissection. If the entry tear is in zone 1 or any zone beyond that, it's a type B dissection. The extent is then added as subscripts. For example, B1 to 11 would be a type B dissection with a tear in zone 1 that extends down to zone 11.
Wait, so you could have a dissection that extends all the way up into the ascending aorta. But if the entry tear is in the descending aorta, SVS/STS would call it type B?
That's right, and that's where the different systems can produce conflicting classifications for the same patient. The paper has a perfect example of this in Figure 10, their case 4.
Let's walk through that. What are we seeing?
It's a 77-year-old patient. The images show an entry tear in the descending aorta, but the dissection propagates retrograde, backwards, all the way into the ascending aorta.
So the ascending aorta is physically involved?
Correct. So under the Stanford and TEM systems, because the ascending aorta is involved, it's an automatic type A, surgical emergency.
But under SVS/STS,
The entry tear is in the descending aorta, which is distal to zone 0, so SVS/STS classifies it as type B. Same patient, two different classifications with very different immediate management implications.
that's a serious discrepancy.
It is. It highlights that these systems are built on different philosophies. One is based on anatomical extent and the risk of pericardial tamponade. The other is based on the location of the primary problem, the entry tear, which is the target for endovascular repair.
And what about those arch dissections, the non-A, non-B ones from the TEM system? How does SVS/STS handle those?
It gets tricky there too. The paper's case 5 shows a dissection originating at the left subclavian artery in Ishimaru zone 2. TEM calls this a non-A, non-B dissection. SVS/STS, since the tear is in zone 2, calls it a type B.
Okay, that seems consistent with its own rules.
It is, but then look at case 6. The entry tear is at the origin of the brachiocephalic artery. That area can be considered distal zone 0 or proximal zone 1, depending on the exact anatomy. So TEM classifies it as non-A, non-B, but SVS/STS could potentially classify it as type A.
So one system creates a new category for the arch, and the other forces it into the existing AB bucket, depending on its precise origin.
Exactly. And the paper argues that lumping some of these complex arch dissections into type B might understate their clinical severity and the complexity of their repair compared to a standard descending aortic dissection.
This all leads to the main point of the paper. What should the radiologist actually put in the report?
Right. The classifications are frameworks, but the report needs to be a practical, actionable document. The authors recommend a harmonized approach.
Which means pick and choose?
In a way, they suggest that for rapid communication, the type component from the TEM system, A, non-A, non-B, and B, is the most intuitive because it's based on the proximal extent, which aligns well with clinical urgency.
So lead with the most dangerous anatomical involvement.
Yes, but then you must follow up with the critical details that the modern systems highlight. First, chronicity. Is it hyperacute, acute, subacute, or chronic? This affects prognosis and management.
Makes sense. What's next?
The entry tear location, specified by the Ishimaru zone. Whether it's surgery or TEVAR, the goal is to cover that primary tear. Its location, its size, and its proximity to key branches like the left subclavian artery are all vital for planning.
Okay, so you state the TEM style type, then you specify the entry tear location using the SVS/STS style zones.
Precisely. Then you move on to complications. This is divided into two main areas, rupture and malperfusion.
Rupture seems straightforward. Is there a hemopericardium, mediastinal hematoma, or hemothorax?
Yes, those are the urgent findings. Malperfusion is more nuanced. The report needs to detail which branch vessels are involved, from the coronaries down to the iliacs. And crucially, it's important to describe how they are compromised.
What do you mean by how?
The paper shows this in Figure 14. Is it a static obstruction where the dissection flap extends directly into the vessel, or is it a dynamic obstruction where the flap is mobile and intermittently covers the vessel origin?
And that matters because?
The treatment is different. Static obstruction might require stenting the branch vessel itself. Dynamic obstruction is often treated by fixing the primary entry tear in the aorta to depressurize the false lumen and stop the flap from moving.
That's a level of detail far beyond type B with renal involvement.
Exactly. Finally, the paper stresses the importance of reporting on high-risk imaging features, especially for dissections that might otherwise be considered uncomplicated.
What are these features?
Table 1 lists them out. They include things like a maximal aortic diameter over 40 millimeters, or a false lumen diameter over 22 millimeters. Also, a large entry tear over 10 millimeters is a red flag.
So these are signs that even without obvious malperfusion or rupture, the situation is unstable and might progress badly.
That's the idea. Features like partial thrombosis of the false lumen or an entry tear on the inner curvature of the arch are also associated with worse outcomes. Reporting these gives the clinical team a much better picture of the patient's future risk.
It allows them to consider earlier, proactive intervention instead of waiting for a complication.
You got it. The authors pull all of this together into a suggested, structured reporting template shown in Table 2. They even provide a sample report for that complex Case 6 we discussed.
Let's look at that. It starts with chronicity, hyperacute, type, non-A, non-B, extent, zones 0 to 9. So right away, you have the big picture.
Then it drills down. Primary entry tear, arch, zone 0, at the brachiocephalic origin. Tear size, 20 millimeters. It's painting a very precise picture.
Next, complications/malperfusion. It lists which vessels are involved, like the SMA and left renal artery, and how, static obstruction. It even notes the near-complete collapse of the true lumen in the descending aorta.
And finally, it lists the high-risk imaging features. Maximal aortic diameter, 27 millimeters. Maximal false lumen diameter, 25 millimeters. Entry tear greater than 10 millimeters. Yes. Entry tear at inner curvature. Yes. It's a checklist of all the key data points.
That's incredibly thorough. It moves the report from being just a diagnostic label to a detailed surgical and prognostic roadmap.
That's the core argument of the paper. A simple label like Stanford A or B is useful shorthand, but it's no longer sufficient. Modern aortic repair is highly technical and personalized, and the imaging report needs to reflect that.
So the bottom line for the practicing radiologist is to adopt a more descriptive, structured approach. Start with the proximal extent using the TEM framework, then systematically detail the entry tear location using Ishimaru zones, document any complications like malperfusion, and list the known high-risk features.
Precisely. It's about translating the images into clinically meaningful anatomical details that directly inform these complex management decisions.
It bridges the gap between traditional nomenclature and contemporary intervention.
Nicely put. The goal is to make the report as precise as the therapies now available.
A clear call for radiology reporting to evolve in step with surgical and endovascular techniques. A very useful guide.
And that's SummaryCast for this week. Join us next time.